We're lucky to have with us one of our honorary AIS members, Dr. Phaik, and she's always happy to join us on short notice and obliges us by giving one of the most amazing talks that I get to hear. And she's going to speak on ruptured posterior polar cataracts. So, Dr. Chee, please go ahead.
Dr. Chee, you are muted. You're muted.
Can you hear me now?
Yeah, perfect.
Yeah, perfect.
Okay. And are you able to see? I'm just trying to change this to a slideshow now.
Yes, ma'am.
Is that okay? All right, great. So thank you very much for organizing this session and for inviting me. And I'm just going to show a simple patient, okay, what I think is relatively simple. And I've named this ruptured posterior polar, and you can see sometimes, to your surprise, this does look like posterior polar cataract. So my financial disclosures with no relevance to my talk today. And this was a patient, 61-year-old male, referred to me by a colleague for bilateral cataracts. And you can see even from this distance that, they really look like polar cataracts in both eyes. But one eye had poorer vision 624, the other eye had 6/9 vision. And the reason was really there was a rip across the posterior capsule, which my colleague didn't notice. So I had to think through carefully, what should I do? Should I make a VR referral for posterior approach to remove the cataract? Should I proceed with phaco and have a VR colleague on standby in case I drop the nucleus? Should I perform femtosecond laser and do hydrodelamination? Or should I avoid the laser because the PC is already ruptured, and so the bubbles may extend the rupture and I may have a dropped nucleus, and then instead I should just do a manual phaco? Or should I just go ahead, ignore all these signs, manage it as a routine phaco surgery, and even offer a premium lens? So let's see what happened. Well, I decided to go along with femtosecond laser, which is really, my routine for even standard cataracts. And you can see it's actually ruptured, all right, on both views here. And so they decided to reduce the offset from the posterior capsule, made it higher than usual, and then proceeded with normal standard settings. So let's have a look at the patient here. So first, I remove the capsule to ensure it's really completely cut. And I'm just using viscoelastic, dispersive viscoelastic, going the subcapsular space and trying to go completely around. And I decided to put another paracentesis on this other side in case I needed to do bimanual vitrectomy. So I thought, well, that would be useful. And that completed my visco dissection just under the capsule up to the equator. And I like to create a little trough for space. And I crack right in the periphery. The rib is right across vertically, so I'm sitting temporally, and I'm just separating the fragments in the 4-quadrant region. All right, trying to avoid the center and my separation. And now I'm going to pull forward this nuclear fragment. And because I've done some visco dissection up to the equator, it comes quite easily. And I do the same for the next quadrant here. And my phaco settings really are unchanged, right? Normal vacuum and phaco energy. And I'm using a Venturi system. So it's a little more difficult on this fragment here, especially between the two instruments. It's harder to chop here or to get it out. So I like to really just levitate it forward. And visco dissection is a very important step because it helps me to get that plane right, just in the subcapsular plane. And then I have this epinucleus, and I'm a bit worried now. I don't know what I'm going to uncover. I know there's a rib there, but I don't want to see vitreous. So I've reduced my settings now to epinuclear mode where it's on linear aspiration, and I put dispersive viscoelastic come out, maintain the chamber space, and then carefully, you can see that little, surge there as I aspirated the cortex. And I'm doing this more in the anterior chamber once I strip the cortex. And I can see the rib appearing there now. You can see right across here. And I'm just careful to stay in the anterior plane so that I don't disrupt the anterior vitreous face. And so we can still continue doing aspiration safely because the vitreous face is still intact. And I'm really, trying to do it very, very thoroughly and carefully. And you can see here that we are making good headway, and you can see this rip right across, and there's a kind of a gap there. Thank goodness my capsular axis is a good size and it's also complete. So I have all my options there. I can place my lens however I want it. So I'm feeling quite happy. I actually had made this other paracentesis, so I could put the viscoelastic evenly right across. And the anterior vitreous face is still intact, and then I inject the lens. This is a non-toric lens. So I told the patient, well, I'll try my best. I know what lens you want. So I actually implanted a single piece trifocal lens into the capsular bag, and then removed the viscoelastic. And that's the surgery for this eye. And he did pretty well. And so he said, how about my next eye? So, well, this eye is slightly different. If I were to use the same lens, I would have to do a toric lens. And you can see this is also the posterior polar, but it is not ruptured. But I told him it's going to rupture, okay? So I had to protect myself. So I said, it's going to rupture. And I shouldn't have jinxed it, but I did. So I'm just going to show you how I struggled through this. So I did exactly the same technique, hoping for the same good luck. So visco dissecting just under the anterior capsule, but perhaps I was not quite as thorough, but I don't think this was the reason why I ran into some trouble. Well, this nucleus was a little softer, and that was part of the reason why it was so sticky. It was like fragmenting to pieces. I couldn't really just levitate it as easily. It was fragmenting. So I pulled forward the pieces. I did not do any trough in this eye, and you can see it's a bit more difficult to get the pieces separate. But I thought, well, I'm making reasonable headway. And then, on this portion here, it really was quite sticky. I can still see my epinuclear plate intact with the polar opacity there. And well, so far it's okay. So now I'm going to remove the epinuclear plate. And I'm really quite scared here because it's really quite sticky. And so I said, well, I saw a big gap there. But I got in my IA and started to aspirate. And you can see as we peel away this polar opacity, it looks like I've got a rip there. Okay, so I'm going to stay away from being too close to the posterior capsule, but I got a lot more cortex to clear. And so I take my time and I strip carefully. When I'm away from the area of the rib, which is right across from equator to equator, I can aspirate quite freely, but when I'm near the equator, I'm a bit more cautious and I go slowly. But so far, so good, because I've not engaged any vitreous, and that vitreous face, anterior face is still intact. So I put in my dispersive viscoelastic, and this gap is really quite big. And now my lens, okay? So this is a toric lens, which is supposed to be aligned in the vertical axis. So I've injected the trifocal lens into the anterior chamber, and I'm rotating the lens in the anterior chamber, and then along the appropriate axis now, I'm then flexing the haptic to drop this haptic into the bag. And I'm very fortunate because the haptic, because the rib was across and not in the alignment of where my final haptic position needed to be in order to correct the astigmatism for this eye. So I managed to get away, and this patient was really quite happy because he had both eyes C6, 6, and 5 unaided with his trifocal lenses. And I told him, you'll be even happier to know you will never need a YAG capsulotomy. So these are just the learning points that Flex really, I find, is really helpful in reducing risk of complications, especially a dropped nucleus. Even like in the case where you already have a pre-ruptured posterior capsule, visco dissection I find is very, very useful in the technique I use. I avoid hydrodelamination, avoid rotation of the nucleus. Sometimes, like in the first case, you saw me cross-chopping and doing just a lamellar chop where I take the nucleus out and leave the epinucleus intact, and then always maintain the anterior chamber space when you come out with your instruments from the eye. And I just showed you how I managed to manipulate the toric lens onto the axis within the bag by first placing it in the anterior chamber. And if you're using flex, if you have already a ruptured capsule, please increase your offset from the posterior capsule to avoid the bubbles rupturing through the defect there, which I've seen before in 1 or 2 of my cases. So thank you very much.